Welcome to the Fight Cancer with Dr. Prasad podcast, your source for the latest, most reliable, and research based information about cancers and their treatments.
Hello, I'm your host, Dr. Prasad Rajdandekar. I am an oncologist and I head the Radiation Oncology Department at Sir H.N. Reliance Foundation Hospital in Mumbai. Today, we are going to talk about breast cancer. And we have the perfect man here to talk about the breast cancer, Dr. Ashutosh Kothari, who is the Director of Breast Oncology Services at Sir H.N. Reliance Foundation Hospital, and many, many other accolades to his name, and one of them being a director also on the European Society of Surgical Oncology. Welcome, Dr. Ashutosh Kothari.
Thank you, Prasad, for having me.
It's a pleasure to have you, Ashutosh, and it's lovely to have you join our team, and it's a great pleasure to work with someone as senior as you, who has been into breast oncology and into the depths of it.
Thank you. Pleasure is reciprocated. We've just been working for 3 months together, but I'm enjoying it already and immensely. Thank you.
So your journey has been very interesting, Ashutosh. A Mumbai boy goes to the UK and then becomes completely entrenched into the oncology community in the UK, and now you're back. How has been this journey for you?
Our journey is long, so since we have time, let me indulge you. We started off with my MS at Tata Memorial Hospital, and that was really eye-opening for me because, as you know, since you trained in the Tata as well, the volumes are tremendous. The impact that has on you does awaken you to a whole different world out there of suffering, pain, and that got me very interested in surgical oncology. So I then did my super specialty training at the Tata Memorial, finished it in 1999, and then as fortune would have it, my wife had got a fellowship in pain medicine in the UK, and she went there, and then 6 months, because she was pregnant, 6 months later I followed. And one of my professors who I'd be ever indebted to, Professor Indranil Mitra, recommended me to his colleague, Professor Ian Fentiman, one of the doyens of breast cancer surgery. And I did a small observership with him, it was a couple of months, and I thought it's a totally different game out there. And he then offered me a job, and then I stuck on. I did my training there, and I became a consultant there. And in 2010, I became the youngest clinical lead of the Guy's and St. Thomas's breast unit. In fact, the Hedley Atkins breast unit was the first ever dedicated breast unit in the world. So as early as 1980s, they decided that they're going to be treating only breast cancer. So it was a vertical split as early as that, and then Hedley Atkins unit became quite famous for that. And I fortuitously became the lead of that unit, and then went on to be the clinical MDT lead of the whole Guy's MDT. I was also, because of my relationship with Ian Fentiman, was very interested in research, so he got me into King's College. So I started teaching undergraduates, postgraduates, and then I got into research. So I sit on lots of international trials, tumor management groups. I have trials to my name. In fact, I've just started one international trial at Sir H.N. Reliance Hospital. So there is a research background. In terms of academics, I've published, I've written textbooks, I've done videos, I hold Oncoplastic classes and seminars across the world, ranging from US to China. I'm a director, as you know, or you've already mentioned, of the European Society of Surgical Oncology, which is a big society and it's quite prestigious for an Indian, the first Indian to be on the board. I also examine for the European Board of Surgical Oncology examinations, both in general surgical oncology and breast surgical oncology. I teach on the MCH courses in India and in the UK for oncoplastic breast surgery. So I have my hands full. And then more recently, I was constantly coming to India to teach, train, and I've been here in and out from 2015, teaching on various courses, conferences. And I found that there's a lack of really good oncoplastic surgery, especially breast reconstruction, because I wouldn't believe, for the love of God, that Indian women don't want reconstruction. And this was often repeated mantra in conferences that I attended, when I used to say that women who come to me in UK, 75% of them have immediate breast reconstruction if they're unfortunate enough to have a mastectomy. And in India, the figure ranges around 1%. And I thought this is because of inequity of access. It's not because women don't want it. And there's lots of other things like de-escalation of surgery, which unfortunately is still not caught up here. So I was thinking there is enough, that I've achieved a lot for myself. And I think it's time I have to come back to my roots and give back to my population. And then, of course, family is here. So that's also a temptation. And that's what brought me back. And of course, the perfect platform was your lovely hospital offering me uh, a role and a free hand to develop the service, which I am really thoroughly enjoying for the last 3 months since I joined in April. So that's me in a nutshell.
Well, that's wonderful, and I think you have come back at the right time. When I was training, and you, of course, much before me, breast cancer was never that much of a problem. Our major problem in India, from women's perspective, was cervical cancer, which was such a huge burden. I mean, I remember when I was in Tata, we used to see 50, 60 patients every single OPD of cervical cancers, and that was a major burden. And now, unfortunately, breast cancer the incidence has increased so much that has become the commonest cancer in India. Initially, it was thought that it is only in the urban area that breast cancer has become the commonest. But now, even in the rural area, breast cancer has become common. So it's wonderful to have somebody like you who has such a deep understanding of the disease, as well as the academic background, to be here to delve into this sort of a problem that we have currently. So, what's happening, Ashutosh? Why is this breast cancer incidence increasing? I mean, this is a question that I'm sure you also get, and I get every single day in the OPD. That why am I having this cancer? Or I know so many people who have cancer. So, what's happening here?
So just to put it in perspective, I mean, you hit on the right spot. Breast cancer today, even in India, is 26% of all cancers is breast cancer. So that gives you the magnitude of what you're talking about. Let's add men to the mix. So if you take both sexes, across both sexes, breast cancer is still the largest diagnosed cancer at about 13%. And if you look at mortality figures, breast cancer kills even now about 23% of women in India. I'm not talking about the West. Now, I think this is multifactorial. One is because we have moved into the 21st century and India has reluctantly been dragged into it. There's a lot of now availability of, internet, smartphones. I think the old cultural, problems that we had with people reporting, with people coming forward, with people talking about their stories. We still, as you know, don't have a national registry for cancer, which is appalling. In a country like ours, where we want to digitalize everything, we're not able to digitalize a simple thing like reporting the number of cancers we've got. So I believe this is a gross underreporting. When we actually scratch the surface of the iceberg, we'll actually find the true numbers. And like you said, in the villages, people come with late stage disease, they come with metastases. So, often the primary is forgotten and we're just trying to palliate the metastases. There's also a big shift to the Western lifestyle. We're moving away from sedentary lifestyles have become, we're spending our life in front of screens. We're not eating the same fresh food and produce that we used to get. And sedentary lifestyle leads to obesity. And all these things, I think, have contributed, like in the West, here. And now people are talking about it. So we are reporting cancers. We are looking at small screening programs, even NGOs. There's patient education. So there is a lot of awareness that is being brought around in patient education. And I think what is important is the message to get across is breast cancer, if caught early, is curable. And that's, I think, the whole ethos of today's talk, that don't hide and feel ashamed of the fact that this is not something that you're being punished because of your bad karma. This is a sporadic happening that can happen to anyone. So we are seeing that shift, and unfortunately, we aren't seeing the shift to early stage. And probably we'll touch on it later on in our discussion today.
Yeah. And lifestyle has become a huge problem. I mean, growing up, everybody was very active. And now, I often ask my patients, how many servants do you have at home? And it's like 4, 5, somebody's doing. I said, just fire them. Or maybe not fire them, but at least start doing something. And being slightly overweight or even grossly overweight is not considered a problem anymore. It is sort of almost being naturalized. कि okay, हाँ इतना तो signs of prosperity, थोड़ा बहुत तो तबीयत अच्छी है, That has become the main thing, that you need to be a little plump, and people don't realize that it's a big problem from you know from hormones point of view. The more fat you have, more estrogen you have, and it's a big concern from the breast cancer point of view.
So you're absolutely right. The problem we are having is linked. So as you very rightly said, if you have a sedentary lifestyle and you don't get enough exercise and you eat all the good food and the rich food that you get in India, which is really tasty, it's difficult to keep the weight off. But if you make a conscious effort, then it's important because, as you know, the whole 70-75% of all breast cancers in women will be estrogen driven. They're not caused by estrogen, but they're driven by estrogen, which means that in postmenopausal women, which are most likely to be affected by this disease, when your ovaries are switched off, you're actually switching your estrogen levels up by putting on weight, because as you know, fat produces estrogen peripherally. And after menopause, that is the sole or the most prolific source of estrogen in the body. So if you reduce fat, i.e. lose weight, your estrogen levels drop and your risk to breast cancer drop. We also know that obesity is linked with chronic inflammation. And just by losing weight, you'll find that inflammatory markers like CRP come down. Regular exercise and boosts your immune system. It enhances your immune surveillance, and your body is better at detecting and destroying abnormal precancerous cells, not cancerous cells. We also can increase our body's ability to repair DNA and reduce oxidative stress, which we know that exercise is able to do. So the antioxidant effects of exercise. So it's not just the weight and the outward appearance. I think it's the whole internal milieu that you change. You create a non-cancer milieu where cancer cells are not able to thrive. And that is what we are trying to drive at. So it's not purely weight. Weight equals estrogen. I think if we get that message through, then women will understand why is it more important. And there is data that comes out by, if you lose weight after breast cancer treatment, especially in ER positive cancers, you actually reduce your risk much more than by taking things like tamoxifen. So this message needs to get through, that it's not just us preaching about weight and like you telling them sack some servants. It's about their own benefit, their own good, and they'll see it as a preventative measure and also as a curative measure if they suffer from breast cancer.
Yeah. And you spoke about exercise, and there's a good amount of data available on women who continue to exercise during and after the breast cancer treatment. The chance of relapse is lower. With this philosophy, actually, many years ago, I think almost 8 or 9 years ago, we started the Onco Rehab program for our patients. So all the patients who are on radiotherapy, and especially the head and neck and breast cancer patients, we send them to a rehab team who's doing a fantastic job. So there they get physiotherapy, which includes aerobic exercises like a little bit of walking on the treadmill, cycling, and many other physiotherapy exercises, along with other stuff like yoga and counseling and dietary advice. And the whole idea of that program, the way we built it, was we help patients to reach a point where they're actually better off at the end of the treatment than when they started. And in the initial phases, we actually looked at the quality of life data of this patient. So we collected their quality of life. We've made them fill a quality of life questionnaire at the beginning of the radiotherapy and then towards the end of it. And our hypothesis was radiotherapy will actually decrease the quality of life because it's cancer treatment. Patients who were on the rehab program, actually their quality of life improved, which was a very surprising finding and a very sort of satisfying finding for us, that something that we are doing is really helping our patients. So our hope is that I keep telling my patients that, okay, you're coming here for rehab for say like a month while you're on treatment, but the idea is that we get you used to doing those exercises and you continue doing them even after you finish the treatment.
I think I know patients who've actually come to you and had this onco rehab, and they've come back and given me fantastic feedback. So to put it in a comparative light, you're doing something which is not offered anywhere else. So I've worked in one of the centers of excellence. Guy's Cancer is, today competing with the Marsden, or even better than the Royal Marsden. And we don't have these because of resource constraints. You have the ability to do that, and it's fantastic what you're doing because you're actually getting their mind off the radiation. You're making them focus on more important things, And they're looking at, so they started their journey into rehabilitation, like you put it, during treatment rather than waiting for treatment to finish. And then there's a void. You've actually started them off early. It's almost like preschool. You're training them early so that there is that interest to continue, because they know that, okay, while I was having this radiation therapy, which most people feel is a horrible treatment, which actually I don't know why, because some people actually have a mastectomy because they want to avoid radiation, but they're happy to have chemotherapy. And I keep telling them, look, radiation therapy is, if you had chemo, radiation therapy is a walk in the park. But if they feel good whilst on treatment, then they know that, okay, when I was in treatment, I felt really good. And then if they stop doing that afterwards, as people have these things where they have low mood swing, especially positive cancers, when you give them tamoxifen, you have problems with moods. And they find that keeping themselves busy and keeping that momentum going actually gets them through this quicker. So, they're on the bandwagon. They just have to keep on rolling and going with the flow. So I think it's a fantastic initiative. It isn't, I think, given enough publicity. And I would like to use this platform to say Prasad and his team are doing this fantastic job. And women actually came to me and said, you said I'll have darker skin, but I don't. And I said, great. You should be grateful to the people who looked after you, rather than saying, because as you know, the darker skin that we Indians have, we tend to get some hyperpigmentation with radiation therapy. So I just warn the patients, to give them a bit of a heads up, saying, look, this might happen. And two of my patients, I remember, very distinctly came and said, but you said it's going to happen, it didn't happen. I said, it's a positive thing, so good. You should be happy, not complaining about these things.
No, that's wonderful. That's really nice to
I
hear.
think we should actually go a step further and do this for patients on chemo, because I was quite surprised when patients are undergoing axillary clearance, and I actually asked the physiotherapist to see the patient before surgery. She was almost in tears. She said, you're the first surgeon who's ever asked me to see a patient before they die.
So actually, we do this while on chemotherapy. So because the OncoRehab radiation program was working so well, the medical oncology, sorry, not the medical, the rehab team actually came up with a program where a rehab physiotherapist goes to the daycare ward and they do, advise patients about physiotherapy. So that happens in daycare every day. So every time they come for for chemotherapy, they sort of get a little. I mean, you can't do much there. I mean,
I know it's a bit busy.
daycare is a little busy, but they do get some advice on physiotherapy. So at least they're sort of, they're constantly told about doing those exercises. So it helps.
I think this is perfect. I think you should also call it probably prehab, because you actually you're preempting the rehab, because you're starting the rehab. Yeah, you're preempting. You're calling it prehab because you're doing this while they're on treatment. So you've started that. Like I said, now that's why I thought of it, preschool and prehab. I think it's a good.
Yeah.
Good,
that's a nice. I think we need to rebrand it.
Rebrand it exactly as prehabilitation, where you make your, because as you know, if you pick up cancer early enough, these women are going to live forever, and they're going to live with the consequences of what we've done to them. So we need to equip them to go back into society as if nothing has ever happened. I know it's a bit difficult, but we can help them. And I think so the patients are our biggest asset, and their motivation, if it starts early, then you find it easier to do. But when they have the weight gain on tamoxifen and letrozole, and they have the lethargy, and they don't have the same drive and the energy that they had before they started treatment, then they find it difficult to come out of that rut and get going full steam. But if they make like a gentle introduction like you're doing now, I think it's a fantastic program. And I've actually spoken to my colleagues in the UK and told them, guys, wake up, this is something that we should be offering.
That's awesome. That reminds me about another thing. One of my patients this morning, I had a meeting with Dr. Sevanti. So I got a little delayed to reach the clinic, say half an hour delayed. And there was this patient who was waiting, in fact, one of your patients who was waiting to see me. And she started getting very anxious because she had to leave for work. And
I know which one.
My secretary calls me, sir, she's like really getting anxious. She has to go. Her client is here, her boss is here, la 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 la. So I came down, I rushed down, I saw her, and she left. One thing which I noticed distinctly, and which then I realized that actually that's the common thing that binds all of us, is stress. We're all stressed most of the time. We're running around. And especially women, they are, working women, especially, they're working, they're taking care of the kids, they're taking care of the family, and there's so much on platter for them. What do you think is the role of stress in this increase in breast cancer incidence?
I think stress is definitely detrimental for any health uh, parameter. If you look at, if you have stress, then you can have things like blood pressure. You have a tendency to having pre-diabetic conditions. So it's the same, I think, that goes with breast cancer. Stress is known as one factor. So if you are a stressed individual, you end to provide more corticosteroid hormones. Those are then broken down in the pathway down. Again, you're producing more estrogen. So there are studies that have shown that if you have a positive mindset and less stress, you are more likely to have less recurrences than if you have with stress. And we also know that one of the leading causes today is our fact, going back to what we said, was our totally unhealthy lifestyles. We are so taken in by the work and running around and stressing about our successes, about money, about how many servants we have, which car we drive, and everything else. I think we get so wrapped up in all this that we don't allow our bodies to heal. We just don't give the body enough time. Sleep, we know that if you sleep for 8 to 9 hours, 25% reduction of stroke. So there is a direct correlation with how we tune our bodies to slow down and the harms, because everything, insulin, spikes that you have with stress, and with stress you smoke, you drink, you eat. So there are a lot of things, little pieces of the jigsaw that finally come together and paint a very sorry picture. So stress and stress busting, stress management today is a major problem of the whole westernized world. In fact, if you look at the US and Europe, 70% of the population is on Prozac, on antidepressants. So it tells you that it's a problem. It's a pandemic. It's not just an epidemic, it's a pandemic, and we need to deal with it. And managing stress. And that's why when you said yoga and mindfulness and simple things like, the old people do pranayam, laughing club. One of my patients goes to a laughing club and she says, every morning, the only thing that wakes me up is I have to go to the laughing club and meet my friends. And I said, great, you must go there, but just take a round of the park with it. Just don't stop at laughing. Take a walk and take one of your friends, and just walk around the park. And she's had a TKR and she's 78 years old and she started doing it. And she said, I used to walk first half a circle and now I can do 2 circles. And I said, great, this is what we should be doing. So yes, unfortunately, with today's lifestyle, stress management is disease management, I would say. Because, putting it mildly, like I said initially, it's not just cancer. It's stress, what we do to release stress, and the other disease that come with it. And the inflammatory markers go up. Everything goes up. So it is, I believe, one of the pandemics that we need to control. And just managing stress will actually alleviate a lot of other problems in our bodies.
Yeah, that's true. And just the diagnosis of cancer also puts so much stress on the patient and their family. And I think that complicates things further. I mean, we do see so many patients who actually have very curable, cancer, but the anxiety of recurrence and the stress of what will happen to my family or me if I get recurrence actually causes a far more damage than the cancer itself. And it's really sad to see them. I mean, we refer them to our mental health experts, counselors, and psychiatrists if needed, because sometimes patients need these interventions to sort of slow down a little bit and calm down from that point of view.
So you're absolutely right. It's not just, so I've always said this, that especially in countries like ours, which are culturally close, we're not nuclear families. We care for each other. And there's still that whole, if not living together, joint family, but there's that culture where, we look after our own. It's a diagnosis that affects the whole family. Because, if you look at a traditional Indian household, the the mother, the matriarch, she's the foundation of that family. It revolves around her. And now imagine if suddenly you take that foundation away. Everything suffers around it. I think what is important is how the message is delivered. I think it's very important that when we are breaking bad news, we do it in an empathetic but a confident way where we tell them, okay, you've got cancer, but we are here collectively, whether you need chemotherapy, radiotherapy, surgery, immunotherapy, tablets afterwards, your cancer is curable. I think that is important for us to stress that you have, and that's why it's important to pick up cancer early, because we can say it to more and more women. If you look at stage 1, stage 2 diagnosis, they make up 54% of the West diagnosis. whereas stage 3, stage 4 make up 54% of our diagnosis. So this is where I keep saying early diagnosis is important, because you'd then be able to say to more women that, with stage 1 disease, 99% of them would live for 5 years at least. With stage 2, about 96% will live for 5 years. So it's a very, very it's not positive, of course, because they've got bad news, but then they start looking at it favorably, that I don't have to go home and start writing my will. I'm not going to die tomorrow. I'm going to be a survivor. And that's what we need to focus on. The fact that we need to drill from the start that provided you're compliant, which is a major problem in India as well, treatment compliance, provided you comply with all that we are telling you. And if you don't like something, tell us. If you don't like chemotherapy, we can de-escalate the toxicity of chemotherapy by giving you slightly lesser toxic drugs. So it is a conversation, and the patient should be empowered enough, I believe. And that's unfortunately not happening enough in India, where they should come back and feel free to tell the surgeon, like, look, I don't like this. Or come and tell you, Prasad, your radiation therapy for 3 weeks is something that's really causing me a problem. Is there something I can do? Can you avoid the boost, or can you make the boost as part of the radiation therapy? And of course, you will then look at the merits of that and talk to the patient, risk benefit, and you'll come to a decision. So we as caregivers, I think the onus is on us to send out a positive picture, to reinforce the fact that, look, you've got it. Maybe you came at a late stage, but talk to your friends, talk to your WhatsApp groups, and tell them to start loving their breasts, start becoming more and more, I would say, health enabled to look after yourselves. So we need to give that message.
Absolutely. In fact, one of the episodes that we did was with Dr. Vanita Narona. She's a geriatric medical oncologist at Tata Memorial Hospital. And our talk was entirely on shared decision making. How do we engage with the patients and their families, and with doctors as not in a pedantic role that, okay, do this and you shall be cured, but what would you like to do, and let's do it together, and let me help you to achieve the best outcomes. And it was a wonderful talk, and especially in case of Dr. Narona, because she herself is a breast cancer survivor. So she brought in her own story of how her sort of outlook towards cancer and the treatment changed when she herself was diagnosed with it. It was a very powerful episode we released in June. So yeah, it was quite interesting.
I think you hit a nerve there, because again, to give you a reference of a patient, just 2 days back, I saw this young, she'll come your way, 43-year-old, high flying, go-getter, 30 years in the United States, came back, diagnosed with bilateral breast cancer. And, we were having this conversation. Perfectly enlightened woman, came with her partner, her mother, and I was doing my role and giving information. And in the end, she said, tell me what to do. And I said, that's not my role. My role is to empower you. As I said, if you were a person who was totally incapable of making a decision, then I would take that and I would say, okay, this is what I recommend. Perhaps this is what's better suited for you. But because you're such a smart person, you're such a vivacious, vibrant young person, you're perfectly capable of making a decision. If you're doing something wrong, we will stop you. We're not going to say yes and agree with something totally off the scales. But if you want something which is doable, which is perfectly safe within oncological parameters, then of course we'll try and accommodate that. And she just looked at me and said, I've never had a doctor say that to me. And I said, well, welcome, welcome to the 21st century. You need to know what you want. And then she said, should I just have a mastectomy? And I said, why? What do you think mastectomy does? And she said, well, I'll live longer. I said, no, you won't live longer. That's a myth. And the minute I said that, she said, what do you mean I won't live longer? I said, no, a mastectomy is not going to give you more survival over breast conserving surgery. And then she said, then why am I having a mastectomy? I said, good, you've answered your own question now. So now we know what you're going to have.
No, that's very important, because the patient need to take control, and they also need to feel not only in charge but also responsible for what they do, I believe, because you don't want a situation where they choose something, it doesn't work out. Maybe sometimes patients have relapses or side effects or whatever, then they don't want to feel that, okay, I made a wrong choice, or my doctor didn't give me right choice or whatever. They need to be fully empowered, and that's the whole point of this podcast also, that we give them information so that they feel empowered and they take the right decisions for themselves. And while we are
just to come in,
sorry.
I think we also need to change our mindsets, and I'm seeing that here, where we as clinicians should relish a patient who challenges us and who asks us to think and give treatment out of the box. I think I would love such a patient. who actually makes me think and come up with something bespoke for her. And I love doing that. But here, patients actually feel that, it's almost a reverence. It's almost like a godlike phenomenon, which I think is wrong. We shouldn't be, fostering this. We should be actually totally saying, no, this has to stop. You are entitled as a patient because, my decisions are mine, but the consequences are yours. I think that's such a powerful statement that my boss told me, that complications are never the surgeons, they're always the patients. So
absolutely.
it's the same thing. Our consequences of our actions, like our treatments, multimodality treatment, they're going to live with it. So they, like you said, if they've empowered and made the decisions, they said, right, this is my decision and I'm going to deal with it. As opposed to this was thrust upon me, I never wanted this, and now I have to deal with it. So it's coming back again to the fact that, the mindset is very important and women need to take control. And today women are educated, they're earning, they're perfectly empowered to make rational decisions. They're everywhere. If you look at women in healthcare today, there's so many. You go to a conference, 70 to 80% of the doctors are women. So perfectly empowered, standing shoulder to shoulder with men. So they should take ownership of everything, including challenging a doctor and saying, no, I don't trust you. Of course, don't read too much of Google and chat GPT and then go to your doctor. That's not. But if you read, proper vetted medical sites, which there are plenty of, and then you read something and you think, okay, I'll have some of that, then it's worth going and talking to your clinician.
Yeah. Now, the ChatGPT reminded me this morning I had a patient whom, so the gentleman has a very rare tumor, a spinal glioma. So a sort of a tumor inside the spinal cord. He's doing very well. He finished his treatment and he came with an MRI report, a follow-up MRI report. Now that MRI said, the size earlier was 2.4, now it is 2.7. So he said, I got very worried about, the increase in size. But my son put this in ChatGPT and we figured out that actually it is not the tumor which is increasing, it's just the swelling. So I felt relieved and I said, yes, ChatGPT is right. There is not increase in tumor. It's actually necrosis, which is good news that the tumor is actually dying. So it was quite interesting. It's probably the first time somebody told me that I uploaded a report in ChatGPT and sort of ChatGPT deciphered it for me, and that's interesting. I think I want to tell this to more patients that just you could use that. I mean, if it's available and if it is reliable, of course, that we have to check how reliable that is. So, Ashutosh, we spoke about obesity, we spoke about stress. The other major thing that again the patients ask is about diet, and I am so sick of it in the sense that every dietitian out there has these bespoke fancy diets that don't eat this, don't drink this, and then you need to eat this type of seeds and that type of fruit, and you import one fruit from Africa and another one from Canada, and it's crazy. What do you think about diet overall?
I think I share your opinion that my simple philosophy in life is KISS. So it's keep it simple, stupid. Don't complicate or overcomplicate anything. So, if you look at our own grandparents, look at our own grandparents who ate sensibly, who ate fresh fruits, fresh produce, look at them and look at ourselves. There is a huge difference in how they are at 80, 85. Their skin is glowing. They can walk. My own mom is 87 and she's active. She's flying off to UK in a week's time without a help, without wheelchairs. I think we are overcomplicating something which is very simple. I think with diet, we need to understand one thing. Again, anything that is sensible in moderation is allowed. Not drinking milk, totally going off sugar, not drinking yogurt because the wounds don't heal, not eating certain fruits, not eating meat, becoming a vegan. It's not going to work. What we need to go back to is, again, your estrogen levels, the anti-inflammatory effects and antioxidant effects. So if you just keep it simple, any food which is processed is high in saturated fats, high in sugars. Again, we go back to insulin, spikes, inflammatory reaction, weight gain, and coming back to estrogen. We also know that foods have an anti-inflammatory and antioxidant effect. So diets rich in fruit, vegetables, whole grain, legumes, antioxidants like vitamin C, vitamin E, carotenoids. All these we don't realize, but they help protect cells from DNA damage. They reduce inflammatory markers, they reduce the inflammatory reaction, like I said before, calorie dense diets, unhealthy eating, binge eating, constantly eating. Anything that causes these insulin surges are going to cause refractory, probably diabetes, and again, weight gain. So try and reduce your fat levels, eat sensibly, avoid high, if you look at anything which has nutrition values, they also have things like glycemic indexes or indices recorded. So white bread, sugar, avoid spikes in your blood sugar, like I said. Fiber is good. So in food, if you look at food, let's look at things like broccoli, kale. These have the word I'm looking for is sulforaphane, and they actually help fight cancer. Berries, all kinds of berries, like our little jamun, which is available very readily. They're rich in antioxidants. Whole grains like quinoa, brown rice, bajra, chana, dals, all these things, flax seeds, which are readily available. Olive oil, if you're a non-vegetarian. Fish, fatty oils, fish has anti-inflammatory. So all these things are perfectly sensible. You don't need to spend a huge amount of money. Maybe it makes you feel better if you spend a lot of money doing all this, but you don't need to. You just need to eat in moderation, sensibly, avoid processed fatty foods, sugars, things with a high glycemic index. Go into fresh foods. Don't eat processed foods. Of course, if you want to go once in a week and eat a pizza, please go and do it. But don't eat pizza as a staple diet for 7 days a week, is what I'm saying. So yes, there's a market. Whenever there's a market, unfortunately, as you know, Prasad, you're always going to find providers. And people will do anything. And unfortunately, cancer is such a disease that people want to avoid it coming back. And they'll go to any extent. And I think that is also being exploited by certain fancy diets and fancy prescriptions and everything else. There are really good people out there who will tell you that it's not just diet. It's diet with lifestyle and exercise and right timing and moderation, and then cutting out the cigarettes and cutting out the alcohol and doing all that. Again, you don't have to become Mahatma Gandhi and not drink or smoke at all. You can have a drink every now and then, but if you start drinking every day, then that's a problem. If you're smoking every day, that's a problem. If you go out once a month and have a cigarette with one of your friends, okay, perhaps that's permissible if that's something you want to do. But doing it every day is not good. So I think it's the whole thing that we have to touch on, the whole lifestyle. And food for Indians is the staple part of that lifestyle. But it has to be taken in a broader context.
Yeah, absolutely. Yesterday I was we have a student in our department now, he's a young American boy. And so we were talking about food and cancer. So he found it a little surprising. I said, so I bring my tiffin from home and it's a little like sort of elaborate lunch. So he was like, do you cook this every day? I said, yes, somebody else cooks it for me, but yes. And I said, we eat different things for lunch and dinner. And he was like, oh my God, that's a lot of work. But I said, that's important because that's how our bodies work. That's how our culture is. So I also tell the patients that I had a Gujarati lady from Marine Drive the other day, and vegetarian, okay, saying, doctor, I have been told to start Mediterranean diet. What is your opinion? I was like, you're vegetarian. And what are you going to survive on? I said, you just have your shak roti dal bhat with salads, everything in moderation, have a good amount of jowar bajra and, dahi and all that thing. So she was happy at the end of it because I was like, you're not going to eat meat, you're not going to eat fish. And then the only thing left for you in the Mediterranean diet is olive oil and salads.
Exactly.
That's not going to help you at all.
But Indians have enough. We have enough in our diets. We all eat green leafy vegetables. We all have a salad. We all have dal. Vegetarians have perfectly healthy diets.
Yeah.
Like I said, if we just explore our kitchens a little more, we will find something that we can make and eat fresh. And you talk about, this is what I used to see in the West as well. When we used to wake up, and I had my friends, children's friends coming home, and they used to marvel at the fact that we used to eat fresh dinners every day. And they would say, wow, do you cook every day? Yes, we do, unfortunately. So yeah. It is, I think, certain things in our culture is good. And that culture, if you look at, Greece does the same thing. Italy does the same thing, and that's why you see them. These are healthy people. Unfortunately, with us, I think we're adopting a bit of a Western culture, and that's why we're kind of paying a price with all the running around stress and no exercise lifestyle. But if you look at all these people in the Mediterranean regions who are doing well, it's because they're following a chilled lifestyle, absolutely, eating all the right things and living forever, which is what we want our patients to have.
Absolutely. I mean, that change, when we say Western lifestyle, actually, it is our lifestyle has become more and more Americanized than something like Greece
The
or
Americans.
Italy, Americans. Yeah. I would love to adopt a Italian lifestyle with a little siesta in the afternoon and a glass of wine here and there with a nice salad with a sprinkle of olive oil. But that's not happening here. Instead, you're getting pizzas and burgers and all sorts of
Exactly.
weird things.
Processed food, when our culture is such fine cuisine. Even my kids say, given a choice, why don't you go out and eat? I prefer a home cooked meal any day because all my life I've eaten out, as you, medical students, you leave home at the age of 18, you're living in hostels and canteens and eating all this food, which God knows what oil and what is in that. We don't even know what we're eating. And we spend all our lives. So for me, given a choice between going to a fancy 5-star Michelin star and eating at home, I'd eat at home any day. Simple food.
Yeah.
I think it's key. We are what we eat is a perfect saying.
Yeah. So we spoke about causes of cancer, we spoke about obesity, we spoke about stress, we spoke about exercise and diet. And these are, to a certain extent, correctable things. You adapt a good, healthy lifestyle, you eat well, you exercise, and, hopefully the incidence of cancer or the chance that an individual, a lady would have cancer will definitely come down. But then the important question that comes up is, if she actually does develop cancer, how do we detect it early? Can we detect it even before it becomes cancer? Or can we detect it early?
We can. So that's, I think, where the whole stress starts. And I think if you just look at the word love your breast, okay? So you look for lumps, you observe your breasts and report something new. If you see something, V is for voice your concern. Speak to a specialist. Don't go to your GP. Speak to a specialist. Come to something like we have in the HN, a one-stop clinic, because it's the most underused, resource that we've got. A one-stop clinic in the West is gold standard. If you have a breast lump, you go to a specialist, a breast specialist. You don't go to your GP who then gets something done and then, it takes you a month by the time you get a diagnosis. So look out for lumps, which is L. Observe your breasts, report anything new, voice your concerns to a medical professional, and echo this message to others. I think this is, so that's where I simple thing when I give talks to patients for patient education, I say, love your breasts, and this is what love means. The other thing you do is breast self-examination. I think it's very important, especially in resource-constrained countries like ours and lower middle-income countries where screening programs are not as prolific, not as accessible, not in villages. Once a month, if you examine your breast, let's say between day 6 and day 13 of your cycle, because that's when MRIs are done, and MRIs are done in that period because the breast is at its quietest. It's not dividing enough. So your breast is soft, you feel less lumpiness, you get used to what your breast feels like. And then once a month during that window, if you go back and examine your breasts, you're looking for lumps, you're looking for bumps, you're looking for hardening, thickening. Observe your breasts, look for any indrawing, look for any changes in the nipple, indrawing of the nipple, any redness, any erythema, any ulcerations, any puckering, lumps in your armpit, lumps under the collarbone, lumps on top of the collarbone. Simple things if you look for, then you try and pick up these things early. But the best thing that you could do is if you went for a mammogram. Now, if you have a family history, then of course we need to do what is called risk-adapted surveillance, where your risk starts much earlier. You have certain tests, and based on your density of your breasts, you will either have a tomogram or an MRI scan and a tomogram. But some sort of surveillance after the age of 40, I think, is important. Because as we are observing, and you're seeing in your clinics and I'm seeing in mine, we're not seeing the 70-year-old grandmothers anymore. We are seeing younger and younger women. So we're seeing women in their 40s and their 50s. And we're picking these women up because they're becoming breast aware, but also because most of these women are now having health checkups and they're doing mammograms. You don't need to have them every year. You probably, if you don't have a very strong family history, doing them every other year or at 18 months is enough. There's this big argument, as you're aware, and that's what really upsets me is, mammograms lead to overtreatment. And I think till you tell me the cohort of patients that I'm overtreating, I want to treat them all. Because you don't know before the cancer is found whether this is an aggressive cancer or it's one of those indolent cancers, which is a chance finding. So I think mammograms are important because if you pick up cancers in stage 1, they're entirely curable. If you pick up, like you said, pre-invasive cancers, before they become invasive, when they're just a local issue, then your treatment intensity de-escalates tremendously. You don't need any chemotherapy. You will need radiation therapy or a lumpectomy or something like that, but you are then cured. So I don't see something as simple as a mammogram, which is not very expensive, to prevent the sequelae of otherwise most prolific cancer in women. It's like having a pap smear. Women used to have a smear before, have a mammogram done every 2 years. That's all you need. And so looking after yourself, being breast aware, loving your breasts, and probably doing something like a mammogram every 2 years. If you can't afford one every 2 years, do one every 3 years. So 3 years interspaced with breast examination every month, I'm sure we'll pick up things early enough. And even if it's a 1 centimeter or 2 centimeter lump, it's still curable.
Yeah.
You don't want those big footballs with ulcers coming to us and then having the chemotherapy and everything else that goes with it. Unfortunately, we are still seeing those patients in our practice.
That's true indeed. We do see sometimes patients who present to us very, very late. But talking of mammogram, I can't help but mention my aunt a few years ago, I think around 7, 8 years ago, she noticed a lump in her breast, and because she's a very independent and independent woman, she went to the doctor herself. Then the doctor said, go for a mammogram. She got a mammogram done. Mammogram came as negative. There was no problem. She didn't tell anybody. Thankfully, the maid in the house mentioned it to her son, my cousin, and then, of course, the shit hit the roof. So he said, first of all, you're going to meet Prasad and figure out. To my horror, and this is very well-to-do family based in South Bombay, to my horror, that mammogram was so poor quality that I said, this is useless. We need to get the mammo done. So I got her to the hospital. We got the mammo done. There was a 3 centimeter sized tumor sitting there. And that mammogram had 2 days ago had told her there's nothing there. So we then got her operated and everything sorted out, and she's doing very well even today. So when we talk about mammogram, I think it's important that we emphasize that please go to a good center which has a good equipment, latest equipment to detect, and also good doctors to sort of diagnose those tumors. Our hospital now has got a very nice mammogram machine with the tomography and all. And also one of the concern that women have, and rightly so, you and I will probably never find out that, is the pain associated with mammography. Like, I have to drag my mother, literally I have to sort of bribe her with all sorts of things to come to hospital and get the mammogram done because it's painful. But now the latest machines have made it much easier, less painful. So I think it's important that women identify that, yes, maybe there will be some pain associated with mammogram, but it's totally worth it. I mean, if you get a breast cancer, I mean, imagine the sort of pain and agony and the trauma that you will go through. So it's worth doing this mammogram than not doing it and avoiding it.
I think you've hit the nail on the head. So our machine is really one of the first machines in Asia to be installed. And the beauty of it is the whole mammogram is done in 3.5 seconds. So you do have pain, but it's for that small duration. And the machine, the tomosynthesis. So like the tomosynthesis, for the people who are listening to us and are not medically savvy, it's a cheap CT scan of your breast. Instead of taking one view from the top and one view from the side, this machine takes an arc of films. Then it uses this fancy software, which is AI. People today love everything with AI. So it has AI, and it reconstructs your breast in 3 dimensions. So it picks up things, it cancels background noise. It's much more, sensitive. It's much more specific. It picks up between 20 and 60% more cancers. So yes, this is why I keep saying, do not go just walk into a mammogram. You need a breast radiologist. You need a proper radiographer. You need the good views. You need to see the whole breast from the nipple back to the muscle. So people have to be trained in doing this. And unfortunately, because, we have a diagnostic center around every corner, people just walk in and say, oh, I want a mammogram today. And then, like you said, it's a very poignant example that you gave, that it can happen to well-to-do people who have connections to doctors. And it doesn't have to happen to anybody. So one-stop clinics, again, like we have at HN, or the machines that we have, good equipment. If you have a dense breast, especially in younger women, the radiologist should be smart enough to say, okay, this is not good enough to you. Maybe we should do a contrast enhanced mammogram like we have in our machines in HM, or maybe we should do an MRI scan, because lobular cancers, as you know, can become really big lumps and they're not picked up on routine mammograms. But if that person sees, on the ultrasound scan, sees some architectural changes, says, okay, perhaps we need to do. So you need someone who's doing this every day, as opposed to someone who just does this because we've got a patient who's walked in.
Yeah. So from the point of view of patients who don't have family history of breast cancer, and you have wide experience from the UK perspective, which has actual guidelines which say, which women should do mammogram and screening at what age. From Indian perspective, what would be your advice to our women, that when should they start screening, when should they stop it, and which screening they should do?
So I think the first mammogram should be at 40 for Indian women. 40, if not 40, okay, you want to push it, let's go to 45, but not delay more than that. Let's say, so in the West, it's between the ages of 40 and 70. I don't see why that should change for India, because we are seeing the same population and the same upsurge in cancers. In fact, we're seeing them younger, so that's why I said 40. Your first mammogram gives you a baseline. It says your mammogram is dense. You need 3D tomosynthesis. You need a contrast enhanced mammogram. As you get older, the breast density decreases, the fatty tissue content increases. It becomes easy to read. So you probably just need a mammogram every 2 years or 3 years till you get to 70. 70, 75, I think we can stop, because then you're probably not going to save many lives, even if the women examine themselves and come back with a lump, yes. But if you want to continue after the age of 75, you're young, age is just a number, you feel that I'm fit and I want, please carry on. It doesn't have to stop, because the radiation you get from a mammogram is minuscule. It's absolutely negligible. If you take 10 flights from across the world, you've made up more than a mammogram. So background radiation in India is high. So I don't think we should be worried about radiation and exposure to radiation, because it's 0.5 to 0.8 millisieverts. It's nothing. So please get your mammograms done. Get them read, interpreted by a good breast radiologist, not just any radiologist. And then go back to the same center, because a mammogram is like a story. You have to compare your old mammograms with the new mammograms to see if there are any changes. So go back to the same center and have your mammograms. If not, get your mammograms physical copy and carry them to your next center if you're moving abroad. Have your reports with you, have your medical history with you, your mammograms, your ultrasound scans, because it is, the breast tells a story of how it changes from the ages of 40, from premenopause to postmenopause to old age. And that story has to be taken in context when you're trying to diagnose things early enough.
Yeah. So, where do you see we are going now in future? I mean, you spoke about AI, and AI is now coming big time into the healthcare, and it's changing a lot of things. Like, for example, even we have a AI-enabled radiation equipment called ETOS. Our mammogram is AI-enabled. So a lot of changes are happening. But from prevention of breast cancer and screening or early detection of breast cancer, what's the future like?
I think the future is very promising, because what I'm seeing is, I was amazed that I've actually operated on a lot of screen detected cancers. But again, we are seeing this in that population which is educated and which is socioeconomically probably in a higher bracket. We have to see this coming down, this whole, and it has to be led by government. It has to be led by policy. It has to be led by, you can't shut your eyes to the fact that is the biggest cancer in women and men. And it's the highest cause of mortality, cancer-related mortality in India. You should treat this like a small little epidemic which is on the rise. I think we need to institute at least self-examination programs. There are lots of things that we can do at primary health center level, where we can train women to examine breasts. The women of the village can come and learn. There was this beautiful initiative started by Germans, which was called, I think, Magic Hands, where blind women, because they have such a keen sense of touch, were allowed to examine and taught breast examination, and they were able to pick up lumps smaller than 1 centimeter, which doctors were not able to pick up. So that initiative, something like this, which is, we have to think out of the box. We have a population of 1.4 billion. Let's face it. We have the joint populations of North America, Canada, South America, Europe, and part of Africa. And we are trying to provide healthcare to all these people. So it's a mammoth task. And out of the 1.4 billion, let's say even half of them are women. That's a huge population that we're trying to service. And we may not be able to offer everyone a mammogram. We may not be able to, but we're able to offer certain basic things like a breast examination. We're able to, through social media, educate, like these podcasts. I did a podcast or an interview for Navbharat Times, and you'd be surprised. The patient came back to me and said, "Doctor, you never told me all this." And I said, "Yeah, but you already had breast cancer. And you were talking about prevention of breast cancer." And she said, "Well, I found it great. I forwarded it to all my friends." So it is catching on. We are getting traction. People are getting the message. And I think, social media is such a powerful tool that we have. Now, like these little podcasts, I'm sure that you are doing this because you have a mission, and I'm helping you because I believe in your mission. And I think education and getting people to become more self-aware. Take ownership of your health. Don't keep on passing the buck to the government and blaming everything on, I don't get these services, I'm poor. You don't need to be poor to examine your breast, or you don't need to be rich to examine your breast. I think patient education is the future. Trying to get something at the primary healthcare level and the district to Jilla levels, and then feeding into central, like a hub and spoke model, which they're trying in Assam. Tata has tried that, the Tata Trust, and it's working really well. And there's no reason why that can't be replicated. Yes, it's resource intensive, but then there are ways of getting around that. Especially things like you have whole breast ultrasounds, you have clouds now, so that can be uploaded and read somewhere by a tech, by someone in Bangalore. We don't need the radiologists there. We need people to train. We get a radiographer trained for a village or a couple of villages, a mammogram mobile van that goes there once a month. I have friends who run programs in Pune and Hyderabad who tell me that women actually run away when they see the van. They don't come because there's no engagement from the village heads. And the village heads always come to them and say, "What's in it for me?" And you think, yeah, what's in it for you is you have a healthy population. That's in it for you. So there is a lot to be done, but India is changing, and I'm seeing it. The reason why I've come back here is I'm seeing that change. I'm feeling that change, and I think I want to be part of that change.
And thank you very much for coming back and being a part of this change. And women need to sort of take charge of their health. I mean, women have traditionally always been in charge when it comes to health and food and everything around the house, and they neglect themselves. I mean, it's so difficult for us to tell women that, you take care of your health. They're like, "Oh, but I have a child, I have a husband, I have, in-laws, I have parents." So I think women need to take charge of their own health and do all these protective things for preventing the breast cancer from happening. So reducing your stress, reducing your weight, making sure that you're eating right, finding time for exercise. And I'm saying finding time because the first thing that somebody says, "Oh, I don't have time for exercise, I'm just too busy." You have to find time. It's important. And get on with the screening program, like Dr. Ashutosh mentioned, that it's really important. Simple things like breast examination can actually save lives. It's really, really very, very important. So thank you very much for joining us today, and thank you, Dr. Ashutosh, for sparing your time. It was lovely talking to you, and we spoke about so many different things. It was really, really nice.
Thank you so much for having me, and I hope the message goes out there, what we're trying to do.
Yeah. And I hope our listeners found today's episode informative, and feel free to ask questions to Dr. Ashutosh and me. Put it in the comment section so that we pick it up and answer your questions there. And we'll reply to you with the correct information about the very important issue that we spoke about. So please do like and subscribe the podcast, but more importantly, share this information with people whom you love. And it's very important because these sorts of information are actually going to save lives. So thank you very much, and hope to see you next time.